Now we'll be starting our 91st webinar for this today, and we have got two learned speakers for today, and the topics will be diagnosis of mantle cell lymphoma by our guest speaker, Dr. Nitin Sood, who is Director Hemato-Oncology, Stem Cell Transplant, Medanta, the Medicity. And second speaker will be Dr. Rajiv Kumar Jain sir. He is Senior Consultant Health in Indian Railways, and he is also Vice President of AUSD. So before we start the session, may I request Dr. Rajiv Jain sir to give say a few words for the welcome address.
Thank you. Welcome, Dr. Nitin Sood. Today is the second week of we had the World Cancer Day. If you look at the call that World Association had called about sustaining the cancer prevention and management strategies for 3 years. So the theme will remain for 22, 23 and 24. So for 3 years, the same theme goes. So it's important for all of us in the Association of Environment and Occupational Health Delhi to have sustained discussions on various kinds of cancers and how we can actually go about preventing and managing, and above all, how we can actually understand the latest research going on in the subject and also try to make it accessible to the population, which is the working population that we have to care for. Besides working population, we care for the members of their families, as well as the people who have given their lifetime to work, and now they are dependent on the medical benefit that they accrue as a result of their long 20, 30, 40 years of working life. So we are grateful that Dr. Nitin Sood, you have spared your time to talk about the important cancer issue, which is, I feel, all of us will benefit. And also, if people who missed will watch your talk over the YouTube channel, which is ENOC, E for environmental, and of course, occupational. And we have a dedicated YouTube channel where all the talks that are given on Saturday evenings are broadcasted and which can be shared later by all the people. So let's start with today's session. Thank you for your time.
Thank you, Dr. Rajiv Jain sir. So welcome, Dr. Nitin Sood sir. So just to introduce you to our organization, we are a association of about 3,000 doctors across India, and we are occupational physicians and public health physicians, industrial physicians from different organizations. So many of our senior doctors, they have joined from across India, and we basically are more interested in preventive and practicing preventive aspect of the health prevention, and saving our workers from the health hazards which are there at the workplace. And then being the medical heads of various public sector undertakings and government undertakings and private corporates, we also have to take decisions regarding the treatment part also, what to do in which case. So in this regards, we would request you to give us a guidelines on what are the causating factors, what will be the if someone is diagnosed, then because since mantle cell carcinoma, as we have studied that it is a very aggressive tumor. So what will be the line of treatment, prognosis, and how can we prevent it also? Because there are a lot of workplace factors also, exposure to solvents, chemicals, radiations, which can lead to this sort of cancers, lymphomas, and especially the mantle this lymphoma. So this was regarding our organization, and Regarding Dr. Nitin Sood, I'll give you a short introduction to all our members. That Dr. Nitin Sood is Director of Hemato-Oncology and Stem Cell Transplant from Medanta, the Medicity. And today he will be discussing on the diagnosis of mantle cell lymphoma. And he has completed his MBBS in 1998 from Mysore University. Post his internship from Safdarjung Hospital, he joined MD Medicine at Delhi University. Then he completed his MD General Medicine and DNB Internal Medicine in 2002. After doing his senior residency, then he moved to UK to train in clinical hematology, and he has been a part of various medical organizations in UK and has been recipient of many awards in the field of hematology and oncology. Dr. Sood is actively involved in various teaching and academic programs as a result, as a faculty of residents as well as nurses at Medanta, Gurgaon. And prior to joining Medanta Hospital, he was practicing as a consultant hematologist at Bradford Royal Infirmary, UK, where in association with Bradford Clinical Trial Units, he was instrumental in managing a massive clinical trial portfolio and setting up phase 2, phase 3 trials. So this background, sir, and we would like to have your experience shared with us regarding lymphoma and especially this mantle cell lymphoma. Dr. Sood, the floor is yours, sir.
Thank you, Dr. Sharma. And that was an excellent introduction. Thank you so much for that. Actually, I've done another talk for this forum before, so I know a little bit about your organization. So thank you so much for inviting me back. I think the last time it was ITP. And Dr. Jain rightly mentioned that we need to talk about cancer, and that's the most important thing. So if we start to talk about cancer, then we know more about how to diagnose it and more about how to treat it. So lymphomas are very, very rare disorders. And so what I want to bring about in my 15-20 minutes is that lymphomas are not only are they rare disorders, they are very difficult to pick up. So it's very important that we have a high index of suspicion and we do the right tests to diagnose lymphomas in time. And when I say diagnose in time, it's very important because the less the disease burden you have, the less treatment you need, and the less complications that the patients encounter, having lesser amount of treatment, lesser money spent, and less morbidity from the treatment itself. So it's important we pick it up early, important that we know the signs that we're looking for, and also important that we look for more common causes of lymphomas or more common differentials compared to lymphomas, and what are the right tests to do to bring out this disorder. Now, as a disease overview, it accounts for a very small percentage of lymphomas, and I'll show you the whole pie because lymphomas is a huge pie. And mantle cell lymphoma, depending on the series that you believe on, is only a small representation, meaning only 3 to 6% in the Western countries, and somewhere in between for if you look at the Indian data. So the overall age-adjusted incidence is 0.64 per 100,000 patients. So let's say in a city of 10 lakh people, you will only have 6 cases a year, which means it's fairly rare. There are many more doctors in a city like that. So very few doctors are likely to encounter that lymphoma, which means that it's important that we know about it, but it's also important that we know how to differentiate it from other disorders. So the incidence increases with age. And as you said, we need to make sure that not only the population that works for us, but also the population that retires and their dependents are looked after, which means as you grow older, the chances of having a lymphoma are higher. And of course, there is very little relation to industrial pollutants or industrial solvents in general. But having said that, we don't know what causes lymphoma. So we have to keep an open mind. And all non-Hodgkin lymphomas we know how it's done. We know the pathogenesis of it and what are the mechanisms responsible for it. But we don't know what in the environment causes it. And for some reason, it happens more in the males than in females. So it's twice And that sort of statistic holds true for the Western and the Indian data. So this is the whole lymphoma pie. And if you look at this, the red part, the diffuse large B-cell lymphomas, almost 1/3 of the pie. And then comes the more aggressive T-cell, NK, T-cell lymphomas, and the other little subtypes, Burkitt's, which is very aggressive. But Mantle is a very small percentage, about 6% of the whole pie. And on the other side of the pie are the less aggressive lymphomas like follicular, small lymphocytic, or now called CLL, and the less common types like the MALT, the marginal zone lymphomas, the extranodal marginal zone lymphomas, and what we used to call Waldenstrom's or lymphoplasmacytic lymphomas. So mantle forms fall somewhere in between of the more aggressive variants, like diffuse large B cell, and the less aggressive, which is the follicular variants. So it has both the non-curative aspect of the less aggressive lymphomas and the more aggressive aspect of the aggressive lymphomas. So in a way, it's got the bad characteristics of both aggressive and non-aggressive lymphomas. The age-adjusted incidence falls somewhere between 4 and 5 patients per lakh of the population, which means about 28,000 new cases will be diagnosed in India per year. And if you look at the SEER database, the Surveillance, Epidemiology, and End Results Program, that says about 0.8 per 100,000 population will have it. So the frequency of mantle roughly similar in India as compared to the Western data. So about 5.6% of all lymphomas, mind you, not all population. So we know how the lymphoma is caused. It's a mature B cell lymphoma. And all of us have mature B cells our um, in our body, in our entire lymphoid system. And the function of the mature B cells is to form antibodies, which help us fight infections, viral, fungal, bacterial, you name it. And these B cells go through various stages and present at various stages in the lymph node, in the bone marrow, in the peripheral blood, and the other organs of the body, which have their own lymphoid structure. Now, these lymph nodes live and die, and they have certain rules where they're supposed to live and die, and these rules are enforced through cytokines. But if there is a problem in these cytokines and downstream signaling becomes a problem, for example, in mantle cell lymphoma, there is 11-14 translocation, which puts the mantle gene right in front of the cyclin D1 gene, right in front of the immunoglobulin heavy chain gene, which is a very active gene. And in turn, the cyclin D1 gets overactivated. And because it gets overactivated, it makes downstream signaling and doesn't let the cell die when it's time to die. Which means the mantle cells then tend to accumulate and occupy space and cause lymph node swelling, cause bone marrow failure, and even lymphocytosis in the peripheral blood. So that's the major problem. And cyclin D1 overexpression is invariably there in the mantle cell lymphoma. It's characterized by presence of the 11-14 translocation. So that puts cyclin D1 gene right in front of the immunoglobulin heavy chain gene. And this translocation causes the overexpression of cyclin D1 and the downstream signaling, which disrupts the cell cycle and doesn't let the cell die. So the cyclin D1 being overexpressed is one of the primary things that we look for when we are trying to diagnose mantle cell lymphoma. And that is what differentiates the mantle cell lymphoma from other non-Hodgkin lymphomas. So if we have a doubt in pathology, that's what our pathologists do. If they cannot, just by looking at the slides, tell whether it's diffuse large B cell, follicular, or mantle cell, they do immunohistochemistry for cyclin D1, which is a fairly standard procedure. And the immunohistochemistry would give us that cyclin D1 is overexpressed, and that kind of makes or proves our point about having mantle cell lymphoma. Of course, this has to be done either on the bone marrow or the lymph node biopsy specimen. which is why it's very important that we get proper sampling for our bone marrows and our lymph nodes. So about 95-96% of cases will have cyclin D1 positivity. But if they don't, then that leaves us in a quandary. And that would mean that we need to have other markers, and SOX11 of overexpression is the other marker that is invariably present in the mantle cells. There are other molecular markers that we can look for, and TP53 mutation. And TP53 mutation is it's a gene which is present on the short arm of chromosome 17. So 17 17p deletion or TP53 mutation, either one of those signify a poor prognosis, and it's across malignancies, especially lymphomas, and across lymphoid malignancies, especially, that if you have a TP53 mutation or a 17p deletion, then that's going to signify bad prognosis, and it kind of helps the tumor with promotion of cell growth. So that makes the cell much more resistant to chemoimmunotherapies, and that makes the cell much more resistant to other targeted agents, and shortens the survival and shortens the remission rate. So mantle cell lymphoma can roughly be divided into two subgroups. The nodal one, which manifests like a traditional non-Hodgkin's lymphoma, which means the patient will have an aggressive disease course. They will present with lymphadenopathy. And this is the more common variant, the largely predominant variant that we find. And it's got an aggressive disease course. It's got B symptoms. It's got night sweats, weight loss. It's got itching in the body and lots of lymph nodes that you can palpate. Fairly easy to diagnose, because the moment you take out the lymph node, the pathologist will tell you in 3 to 4 days that this is mantle cell lymphoma. It will have cyclin D1 expression, overexpression, SOX11 overexpression. And of course, if you do genomic testing, then there will be a high degree of genomic instability. But the smaller version of leukemic non-nodal mantle cell presents in a very different way. The way it presents is the patient will be unwell and will come to you for a blood test. And as doctors, we notice that there is a huge amount of lymphocytosis. And when we see lymphocytosis, a white count of 50, 60,000, the patient in front of you as well, we see the hemoglobin is okay, the platelets are relatively okay, especially in early stages. We suspect lymphoid disorders like chronic lymphocytic leukemia, and it's only through flow cytometry, which looks at specific cells or specific markers on those lymphoid cells, that we can tell the difference between CLL, which is the overwhelming majority in that clinical presentation, and the difference between mantle cell, because the flow cytometry will give us markers that are entirely different in these two diagnoses. So we'll talk about those markers, but these are the signs and symptoms that mantle cell lymphoma patients present with. And these are certain signs and symptoms that all lymphomas present with. So it is not that we can tell the difference between different lymphomas based on these signs and symptoms. So most of them will have loss of appetite, and any cancer patient has weight loss. A lot of lymphomas have fever, and the fever is traditionally low grade, sort of evening rise of fever, a bit like tuberculosis fever. And the patient notices it in the evenings, but it's persistent and nobody's sort of figuring out what this fever is, and it's gone on for weeks and weeks. The patient can have nausea depending on what kind of medication he's on and whether there is gut involvement. But night sweats is something that is very striking if it's there. And night sweats is something that the patient will describe as being sweating so much that his bed sheet would get wet, and he'll have to wake up and change it, and happens 2-3 times a week. And that's a symptom that is very difficult to miss. And of course, sometimes the patient tells you about the enlarged lymph nodes, but sometimes you have to pick it up on clinical examination. So they could be cervical nodes, they could be axillary nodes or inguinal ones, and you could have hepatosplenomegaly. Fatigue is fairly common in most malignancies, and lymphomas are no different. So the way to diagnose it, and this is a constant problem when you see a patient with fever, night sweats, and weight loss, and you palpate the nodes. The question really comes is whether you should do a fine needle aspiration, which is a much more accessible test, or whether you should do a biopsy. And if you should do a biopsy, which type of biopsy? So the answer to that question is not very easy, because being a country where prevalence of tuberculosis is so high, and tuberculosis can present with similar symptoms, sometimes FNAC is probably a more important test. But if the suspicion of lymphoma is high, then biopsy becomes very important, because unless the pathologist gets the whole lymph node and looks at the architecture of the lymph node, they won't be able to A, tell it's lymphoma, or B, tell which type of lymphoma it is, and C, put IHC markers. So FNAC is no good for any of these. FNAC just gets us some cells, doesn't show us the architecture of the lymph node, and sometimes gives us the opportunity to do the IHC, but most of the times IHC is not possible. And unless you do IHC, we won't know what the CD5 status is or CD23 status is. CD2010 are adjuncts, but cyclin D1, SOX11, as we just looked at. And unless we do these, we won't be able to say whether this is lymphoma, or it's an aggressive carcinoma, or if it's a lymphoma, which type of lymphoma it is. So histology from a very good biopsy, preferably from a lymph node, are the ideal tests. And when we come to scanning, then to start with, a CT scan is a very good starting point, especially a contrast enhanced CT scan, which would give us all the lymph nodes. But then we eventually have to do a PET scan as well to stage the disease. And of course, the other blood tests are adjuncts. And in the slightly uncommon variant of blastoid morphology and the leukemic version of mantle cell, then blood tests and flow cytometry becomes more important. So how do we stage it? I mean, we stage it depending on the bulk and the extent of disease. And the bulk and extent of disease very fairly easily picked up either by a CT scan or a PET scan, depending on what kind of access you have. And if the lymph nodes are a single region, then it's stage 1 disease, which we very rarely see, to be honest. But if you have two nodal regions, but on the same side of diaphragm, that becomes stage 2. And roughly speaking, the moment you cross the diaphragm and it's on both sides of the diaphragm, that is stage 3. And if you have liver or bone involvement or lung involvement being rare, liver and bone marrow involvement obviously being more common, that becomes stage 4. So this has implications on treatment, and this has implications on the way we say the prognosis to our patients. So this is overall survival according to MIPI, and MIPI is Mantle International Prognostic Index, MIPI for short, and it's a well-validated score. And we'll again look at MIPI in detail later in one of the other slides, depending on time. But MIPI looks at various factors at diagnosis to say what kind of risk the patient presents. So if you see median survival not reached in the top blue curve, which is the low risk ones, and median survival as short as about 24 to 30 months in the high risk variants. So your lifespan could be 2.5 years, or it could be 10 years, depending on what kind of MIPI index you have. So which means that to prognosticate, you need to know many more things about the lymphoma, and not all mantle cell lymphomas are the same. So Ki67 is the proliferation rate and how fast the lymphocytes are proliferating. And again, Ki67 is something that we can only do on a biopsy, which is where the biopsy becomes important. And if you look at the survival rates between different Ki67s, statistically significant, all the survivals according to Ki67 being very different. This is the IHC that I was talking about, and depending on the CD5 and CD23 status, you can differentiate mantle cell lymphoma which is CD5 positive and 23 negative, from follicular small lymphocytic, the more aggressive variants, the less aggressive of systemic marginal zone and extranodal marginal zone lymphomas. But the essential differentiation is between mantle cell and CLL in a leukemic phase. So this is the MIPI we were talking about, and depending on how old you are, what your performance status is, what your LDH is, and what your white count is, Ki67 status, you give scoring to each one of them. And a low risk will be if you score 0 to 3 points, and a high risk is 6 to 11 points. Anything in between is an intermediate risk. And if you look at the Kaplan-Meier curve on the left, the low risk median survival not reached, and versus the high risk median survival of only 29 months. So depending on MIPI, then we decide on how aggressively we need to treat and how far we need to go from a treatment point of view. And I'll show you that the young fit mantle cells, we have to go as far as to do a bone marrow transplant to get rid of that disease, especially if it's high risk disease. So goals of therapy is to reduce tumor bulk and to reduce symptoms to start with. And the indolent stage, sometimes not all mantle cell lymphomas will need treatment at diagnosis. So if you have extensive disease and if you have no symptoms from it and it was incidentally picked up, then and it's a indolent disease, you have a low MIPI score, then you can watch. Early stages, especially if it's stage 1 disease and is limited to one lymph node area, and all you need to do is radiate that part and it's gone forever. But we rarely pick up the disease at that stage, which is a tragedy. But if it's advanced or symptomatic disease, then and you can tolerate chemotherapy, then chemoimmunotherapy becomes the cornerstone of treatment. And if you cannot tolerate chemoimmunotherapy, we have targeted agents now, or milder forms of chemoimmunotherapy, which some of the elderly patients may benefit from. So not all patients need treatment. The ones who have non-nodal presentation, the ones who have hypermutated IGH genes, the ones who have non-complex karyotype, sometimes observation is recommended. If you have low proliferative disease, smaller nodes, less proliferative indices like LDH and beta-2 microglobulin, no B symptoms, asymptomatic morphology, and no blastoid morphology. But if you do decide to treatment, then depending on whether you're eligible for a transplant, if you are fit, young, eligible for a transplant, then you should have good treatment, meaning chemoimmunotherapy, followed by a bone marrow transplant, even followed by maintenance rituximab or anti-CD20 antibody. But if you're not fit for chemotherapy, then ibrutinib and the other newer BTK inhibitors become more important. So if you relapse, then the problem with relapse is there's no standard upfront treatment for relapses. And relapse disease, by definition, becomes fairly poor prognosis in itself, especially if you relapse after a transplant. And if you relapse after a transplant, or even if you relapse before a transplant after a BTK inhibitor, and you're young and fairly fit, then the end game or the end point for the treatment becomes an allogeneic transplant. And if you're eligible for an allogeneic transplant, then salvage chemotherapy becomes very important. And after salvage chemotherapy, you can think of a transplant. So the many various other options available, like the novel agents of ibrutinib and acalabrutinib now. So if you respond after one of these novel agents and you're fairly fit after one of these novel agents, then transplant again becomes a good option, or maybe maintenance rituximab becomes a good option. So that depends on a lot of other factors as well. So for a relapse disease, this is what NCCN guidelines suggests. This is the updated version of April 21. And the preferred regimes in alphabetical order, if you look on the left, are the BTK inhibitors, which are now approved, acalabrutinib, ibrutinib, with or without rituximab, or a newer version of BTK inhibitor, which we don't have access to at the moment, is zanubrutinib. The other useful agents are the older ones that we used to use, the bendamustine rituximab, the bortezomib rituximab, especially DAP, which is what we use very commonly now, and gemcitabine oxaliplatin combination. And of course, allogeneic stem transplant remains a good option. No talk on lymphomas now is complete without talking about CAR T cell therapy. And one of the third line agents they've recommended is a CAR T option. And CAR T cells are our own T cells, which are extracted, modified, genetically modified, and then infused back into the body. Mantle cell lymphoma lags behind in CAR T research at the moment, but many aggressive lymphomas are well versed, and a couple of CAR T products have been approved for those. So with that, I thank you for your patience and for your attention. And if there are any questions, I'm quite happy to take it.
Yeah. Thank you, sir. You've given a very nice summary of the mantle cell carcinoma, mantle cell lymphoma, and we have we have understood the whole etiology, pathology, and the treatment part very well now. The basics are there with us. So regarding treatment, sir, I want to again ask you that because a lot of these immunotherapies and many of the new molecules which are there, which have been approved by the FDA, are they have been approved by our drug controller in India, CDSCO, for use in our Indian patients?
So the CAR T is not available in this country at the moment. The ones that we have approved is the chemo immunotherapy combinations, things like R-CHOP and bendamustine rituximab. Those are approved for mantle cell lymphoma. For relapses, we have R-hyper CVAD, which is approved. And for relapsed mantle cell lymphoma, where chemotherapy is not a good option, then we have two drugs approved. One is ibrutinib, which was approved 4 or 5 years ago, and we have the sort of generic options available. And the other drug that is approved is acalabrutinib. And acalabrutinib, the advantage of acalabrutinib is it's a second generation BTK inhibitor. And second generation, it's a more selective BTK inhibitor, which means there are off-target effects or off-target kinase inhibition is much less. And that off-target inhibition is not something that we desire or we want. And off-target inhibition causes much or many of the side effects that we don't want, which means side effects like atrial fibrillation and bleeding, bruising, and diarrhea, or even joint pains. So off-target side effects being less, acalabrutinib has become the preferred option. But obviously, the no generic is available, so it's a much more expensive option at the moment. But zanubrutinib is not approved in this country. No CAR T cells have been approved so far.
Right. So, Dr. Rajiv Jain, sir, he has raised his hand.
Well, Dr. Nitin, you have very concisely and comprehensively talked about mantle cell lymphomas. There are two questions which are coming in my mind. First is the role of molecular diagnostic facility which you can trust. That means hands-on, you can interact with the people who are doing the medical diagnostics testing, because you have to do it repeatedly and you have to do it during the course of treatment, not only during remission but relapse as well. Second question is, if the role that ibrutinib played earlier has changed over the years. Initially it was relapse, now it's for primary treatment as well. So what are your take on that, the role of ibrutinib in management of mantle cell lymphoma?
Yeah, so very, very good questions, actually. You're rightly said on the diagnostic laboratories that you have to have a specialized pathologist who looks at lymphomas day in and day out. And that's what we've developed in our hospital, in our institute at least, because lymphomas are so complicated and the diagnosis is so difficult, that if you're not looking at lymphomas day in and day out, it's very difficult to diagnose them. It's not only difficult to diagnose them, it's also difficult to decide which IHCs to put and then interpret those IHCs. Which is why we have an in-house team of pathologists who look at these, headed by Dr. Gautam in our institute. So they're very good. And because they have so much experience in lymphomas, they give us an accurate diagnosis most of the times. Obviously, they have access to very good IHCs, and that's important because unless you have access to good tests, your expertise is not exposed to those good tests, then what good is expertise unless you can apply it? Which means you need a good testing laboratory, you need a good team of pathologists who look at the whole thing day in and day out. So you're very well made point there. And about the ibrutinib, that's correct. I mean, ibrutinib is coming up the chain now gradually, and being incorporated into regimens which are coming as frontline regimens. But none of the regimens approved upfront so far for sort of upfront treatment of mantle cell lymphoma. Upfront treatment of mantle cell lymphoma remains dominated by chemoimmunotherapy agents. So the front runner at the moment is the R-CHOP RDAP combination, which gives better progression-free survival than R-CHOP on its own. But as hematologists are more sort of used to doing R-CHOP, we don't, or we haven't really caught up to that study very much. Most people sort of do R-CHOP on its own because there's no overall survival advantage as yet. So when such trials come in, it's also important that we look at mature data, and the data hasn't matured yet to incorporate ibrutinib or acalabrutinib, for that matter, zanubrutinib, into the upfront treatment lines. But they've come up to second line treatment. So second line treatment, they're one of the preferred or favored options now. But as you rightly said, they will come up the chain eventually.
Okay. Related issue is, how has been your experience in mantle cell lymphoma in Vedanta during the past, say, 5 years?
So mantle cell lymphomas progressed from a terminal disease to a very manageable disease now. And in fact, in younger patients, we are able to give them intensive chemotherapy, even transplant them, autograft being not a very difficult or a very high mortality procedure, which means that most mantle cell patients, if they can tolerate a transplant, can expect almost a 50 to 60% cure rate at diagnosis.
That's very good, actually.
So that is where the progress comes in. That is where the more intensive the treatment, the earlier the diagnosis. That is where that is where the efforts of the research comes into the clinic very quickly. And even with the relapse diseases, we used to have very few options, and now we have ibrutinib and acalabrutinib both, and we have access to sort of cheap or generic ibrutinib. Which means we can treat a lot of patients and give at least progression-free survival to them.
Great, thank you.
Any other question from the panelists and the participants? I'll summarize your session, sir. It was as Dr. Rajiv sir said, it was a very concise and comprehensive presentation, giving a lot of insight about this mantle cell lymphoma. Yes, as we grow and as we age, especially our employees, we have to keep a follow-up with them, and they might be having some mild symptoms for a long time, and they need to be followed up, and in case there is doubt, then we should definitely get them investigated. Incidence is more in males than females. Environmental factors, dietary factors, they also contribute a lot. as the study shows. So being an occupational physician, we need to take care of these factors and keep them in mind. And primary thing that we have to look for is the cyclin D1 protein. That is more important, and that is the main basis for the diagnosis of this mantle cell lymphoma. And these mild symptoms of loss of appetite, low grade fever, weight loss, night sweats, especially, we should not ignore them, and we should always go for the blood test and uh, get them diagnosed. And whenever there is suspicion, we should rather go for a lymph node biopsy if lymph nodes are enlarged, rather than going for FNAC, because echo texture of the lymph node, that will give you a better uh, idea of the disease. And then we may also go for CT scan and PET scan, because they are also quite helpful in the final diagnosis. And staging is very clearly, sir, you have told that if it is single lymph node, it is stage 1, 2, or more lymph node group on one side of the diaphragm. They are stage 2, stage 3 is on both sides of diaphragm, and if the other organs they are also involved, that is stage 4. Now it is very clear to us about this staging of this disease, and this MIPI score is also very important for the prognosis. And treatment part you have already explained a lot, sir. And only thing is, although these treatment part, they are costly, they need to be approved by the respective managements in case they are required. So we would request for some guidelines from you all, so that these treatment, wherever required, they can be approved, and the patient can benefit from these available treatments at least. So with this, we can conclude, sir. Dr. Nitin Sood, sir. This was a nice, fantastic session. And
Thank you. It was a pleasure.
yeah, thank you very much. And now our second topic is regarding our weekly COVID Epid updates. And for this, the speaker is our Vice President of AUSD, Dr. Rajiv Kumar Jain. He is Senior Consultant Health, Indian Railways, with more than 40 years of experience in health and hospital administration. And he is fellow awardee of IPHA and Indian Association of Occupational Health, and Association of Environment and Occupational Delhi. And he has published more than and presented more than 145 scientific papers in national and international conferences, and fellowships and scholarships from WHO, NIH, USA, Canadian Society for International Health, and International Clinical Epidemiology Network, and International Society for Priority in Healthcare. So, Dr. Rajiv Kumar Jain, sir, we can start with the COVID Epid updates, so that we are more aware of the.
Thank you, Dr. Sandeep. Before I start, I must congratulate you once again for getting elected to the board of the International Commission on Occupational Health for the term 2022-2024. And I believe your presence in the International Commission on Occupational Health shall be beneficial not only to the occupational health physicians in India, but across the world. Today, we are again here on a Saturday evening to have a review of the COVID-19 epidemiology. And it's good that in India, we are seeing a kind of control, a kind of fall in the incidence of new cases, and the fall in terms of deaths as well, which is a good sign. But does that mean the pandemic is over? We shall see with the data that we have. Let's start. Next slide, please. Well, yesterday was 11th of February. And every year, 11th of February is celebrated as the International Day for Women in Science. The face of WHO's COVID-19 pandemic has been Dr. Maria van Kerkhove. Let's see her glimpse of her life.
My name is Maria van Kerkhove. I am the head of our Emerging Diseases and Zoonoses unit in the Health Emergencies Program. And I am also the COVID-19 Health Operations and Technical Lead for the pandemic. I am an infectious disease epidemiologist, which basically studies epidemics, why certain people get sick, why others don't. What are the pathogens that are causing people to get sick? What causes the outbreaks? How do they start? How do they spread? How do we control them? And our main role is to design and develop and implement prevention and control programs to better understand where these pathogens come from, how we could better limit their potential to spill over from animals to humans, and to prevent the onward spread. We develop guidance and advice, we develop trainings, we have a laboratory group that works on the rapid development of diagnostics, and we work with partners all over the world to implement these programs. I grew up in upstate New York, and I didn't know much about the UN or WHO in my little bubble, but I became really interested in virology and in these infectious pathogens, and I did a master's in epidemiology at Stanford University. And after I did my master's, I needed to get a job and start paying back some of my student loans. I worked for a company in New York. After a few years working there, I was ready to go back to school and to do my PhD. In doing my PhD, I spent a few years in Phnom Penh, Cambodia, working on H5N1. We followed people with the birds on the back of their motorbikes and just tried to understand what was the circulation of the birds to mimic the potential circulation of H5N1. It was fascinating. I absolutely loved working in Cambodia. And from there, I just learned about WHO and what WHO was meant to be doing. And on and off, I was working with WHO. And then I became the MERS coronavirus technical lead in 2017. And then the rest is history, I guess. I've worked incredibly hard, but I also have a very, very supportive husband who's always believed in me and believed in my career, and we've done this together. So I am also very grateful for that. Together, we've been married 18 years now, and I'm just really grateful to have him because I wouldn't have been able to do it without him.
I'm declaring a public health emergency of international concern.
I had returned from one of the first missions to China in February 2020. The outbreak had largely been brought under control in China, but it was really taking off in a lot of places, and there was a lot we didn't know. Cases were increasing in Switzerland, and I was worried about exposing my kids and my husband to this unknown virus. And so I and my husband, we made the decision that I would quarantine myself from them. I would isolate myself from them. And so that was hard. It was about 2 months that I didn't hug them or touch them, and it was awful. I beat myself up about it every day, and there are others who have made judgments about me on that as well, but it was awful. But I thought I was doing the right thing. We thought we were doing the right thing to protect them. And sometime in May, it just became too much. And one day I came home, it was a weekend. I had come home and my little one, so he was 1.5 years then, he just came running up to me and just gave me a big hug, and I just couldn't not hug him anymore. So that was a pretty painful time for us. The job that I have is one of privilege, and it's one that I take very seriously. Part of that is the public speaking. That was never part of the plan. I don't really have training in this area.
This is not the situation we should be in when we have tools at hand. There are 4.
I'm very grateful to represent WHO at these press conferences and in the live Q&As that we have, and I sit up there with amazing people. Part of the communication is through interviews, and part of it is also on social media. I have to say, I struggle with social media. I think many people do. It's one of those platforms that is a blessing and a curse. Sometimes it really gets to me. There's some pretty awful things on social media. There's also some supportive things. I guess you tend not to hear the positive and you really focus on the negative. Some of it I've struggled with, especially when my family is brought into it, my kids are brought into it. We are expected to communicate regularly, and this is hard stuff to communicate. It's very complex, and there is no short answer. There's no yes or no, and everybody wants a yes or no. I want people out there to know that we're on it, and I think we're all doing the best we can. I'm proud to be WHO. I'm proud to work alongside the thousands of WHO staff in Geneva, in our regional offices, in our country offices. I draw inspiration from all of you, and I am so grateful you're on the front lines and working with people in country to advocate for what we stand for. I'm proud to be one of you.
So friends, we go on from seeing a human face to the pandemic at the global level. Next slide, please. Yes, from the global face to the face of India for the pandemic. Let's listen to him as the key spokesperson on COVID-19 management in our country. Dr. V.K. Paul, Member Health, Niti Aayog. Let's listen to him, what he has to say regarding COVID-19 situation, especially the mRNA vaccines. The mRNA vaccines are the vaccines for the future, not only for COVID-19, but for all time to come. They will be the front runner vaccines for many other diseases, even today and in future. So let's listen from Dr. V.K. Paul, what he has to say about
from individual to individual.
Okay, 86.
Sir, I'm Monica from the Hindu Business Line. Sir, I want to know how badly we need mRNA vaccines, because according to experts, mRNA vaccines, they can be easily tweaked depending upon the new variant. And we still don't have any mRNA vaccines. And also, I want to know about the Zydus Cadila vaccine. Can it become a competitor to mRNA vaccines?
इस कोविड की वैक्सीनेशन की जर्नी में बहुत सारे फ्रंट पे, बहुत सारे प्लेटफॉर्म्स पे वैक्सीन बने. ये भी एक बहुत ही नई चीज़ हुई है, बहुत बड़े स्केल पे. और फॉर्चुनेटली हमारे देश में मल्टीपल प्लेटफॉर्म्स के ऑप्शंस हमारे पास अपीयर हुए, R&D में भी और मैन्युफैक्चरिंग में भी. वी आर वेरी प्राउड दैट वी हैव अ कैंडिडेट वैक्सीन बाय जिनोवा, which is entirely an Indian development. और वो वैक्सीन, जैसा कि आपको विदित है, फाइनल क्लिनिकल ट्रायल की स्टेजेस में है, और हमें उम्मीद है कि वो उस थ्रेशोल्ड को पार कर जाएगा कि उसका इस्तेमाल किया जा सके इमरजेंसी यूज़ के अंदर एंड देन रेगुलर यूज़ समडे. उसकी खासियत भी आपको मालूम है, लेकिन कहना भी चाहिए. पहली बात है कि वो नॉर्मल कोल्ड चेन कंडीशंस में सर्वाइव करता है, स्टोर किया जा सकता है, ट्रांसपोर्ट किया जा सकता है, दिया जा सकता है, विच इज़ अ बिग थिंग. दूसरे वैक्सीन जो है वो सब ज़ीरो टेम्परेचर पे रखे जाते हैं बहुत, और उनको फिर सारी व्यवस्था बनानी पड़ती है. सो वी हैव अ ग्रेट कैंडिडेट. उसके अलावा उन्होंने इंट्राडर्मल देने की भी पद्धति की ईजाद करने की कोशिश करी है। इंट्रामस्कुलर की बजाय इंट्राडर्मल जेट से दे पाएँ तो वो भी ईज ऑफ ऑपरेशन करेगा। ट्रिमेंडस एडवांटेज एंड वेरी इनोवेटिव। थर्डली, उन्होंने ये भी विदित है, आपको पब्लिक डोमेन में है, कि ओमिक्रॉन के लिए भी उसको ट्विक किया है। वो डेवलपमेंट भी पीछे पीछे चली हुई है। मेन वैक्सीन यहाँ पहुँच गया है, लेकिन उसी को प्लेटफॉर्म, और वो इम्पॉर्टेंट बात है, उसको मैं आगे और बताता हूँ, उन्होंने उसको ट्विक करके ओमिक्रॉन के लिए भी बना के आगे वो उस जर्नी में चल पड़े हैं। वो धीरे धीरे आगे आएगा। नाउ वी नीड द mRNA platform because it is a new platform. It has been shown that the vaccines developed on this platform, at least for corona, have been effective worldwide. Having an India vaccine and vaccine platform available is for us an asset today in the wake of COVID, today in the wake of Omicron, but tomorrow also beyond it for other diseases for which the vaccines have been eluding us. It could be malaria, it could be dengue, it could be TB, a better vaccine. There are so many diseases for which we still are hunting for an affordable, effective, lasting vaccine. So we treasure this platform and we compliment the company and the group that have gone into it. So as a platform, it will continue to be important in the medium term and near future and beyond. As an option in the fight for corona SARS-CoV-2 pandemic, it remains relevant, just as so many other vaccines are relevant in the world. And we have the other vaccine जिसका आपने जिक्र किया है, वो अपनी जगह है, उसमें भी ये सारी चीज़ें जो अच्छाइयाँ हैं, जो उसके गुण हैं, नॉर्मल कोल्ड चेन कंडीशंस की बात है, इंट्राडर्मल एप्लीकेशन की बात है, वेरी फ्यू साइड इफेक्ट्स की बात है, सेफ्टी भी डेमोन्स्ट्रेट होगी बच्चों में, तो वो जो सारे गुण हैं, दीज आर ऑप्शंस दैट आर अवेलेबल. वी आर फॉर्चुनेट, द वर्ल्ड इज़ फॉर्चुनेट, बिकॉज इंडिया के ये वैक्सीन जो हैं वो हमें ये ऑप्शंस देते हैं. और ये साइंस की जर्नी तो चलते ही रहना है. अभी नहीं मालूम ये कहाँ तक लेके जाएंगे. अभी लोगों ने वैक्सीन की रिसर्च कोविड के लिए कोई कम नहीं कर रही है, वहाँ कंपटीशन भी है और आगे की परिस्थितियों के लिए भी तैयार होना है. सो इट्स अ ग्रेट डेवलपमेंट एंड वी ट्रेजर इट.
So I would just add that this is another vaccine in our armamentarium, which is going to be useful, as Sir has said, which really establishes that India is heading towards becoming a vaccine superpower, number one. And number two, the fact that these vaccines are going to be available for other diseases. And the last point that I want to mention is that because such a large proportion of our population has been vaccinated, we are not seeing such a disastrous third surge in terms of hospitalizations and mortality. That protection has been provided by the extreme 96% vaccine coverage first dose, and that I think is a major strength of the nation.
Number 5.
So, friends, you have heard Dr. Balram Bhargav and Dr. V.K. Paul about the mRNA vaccines and India becoming a vaccine superpower. Let's get back to epidemiology of COVID-19. This is the last 24-hour situation of COVID-19 in our country. Where you see all the states and you see the summary at the top. 50,137 new cases, 804 deaths, out of which 251 backlog from Kerala, and 14.5 lakh tests yesterday. 7-day average test positivity rate is still above 5. It is 5.1%. 6 lakh active cases are there in the country, but they are shrinking by 10.6%. Total 4.26 crore cases of COVID-19 in the country, with more than 5,08,012 deaths reported. 172 crore vaccination doses given yesterday, 47 lakh yesterday. But if you look at the confirmed cases, still you find Kerala is at the top, both in terms of cases and deaths. And Maharashtra is number 2, both in cases and deaths. And number 3 is Karnataka in cases and deaths. Tamil Nadu is number 4 in cases, and West Bengal is number 4 in deaths. and Tamil Nadu is number 5 in deaths at the moment, last 24 hours. Tests per million per day is still at the bottom are Uttar Pradesh, Nagaland, Arunachal, West Bengal, Andhra Pradesh, and Meghalaya. 7-day average test positivity rate is coming down, but Kerala and Mizoram are area of concern with 27.4% positivity rate, and Mizoram is 26.5% positivity rate. But the best news is at the right side. The growth of active cases, India is minus 10.64%, and all the states in the country are at present minus. And the minimum minus is Mizoram minus 2.76, Sikkim minus 3.66, West Bengal 4.93. It's all good news that the pandemic, the third wave, is on the wane. At the moment, it is falling all over the country. We shall see the real situation in terms of districts later. Next slide, please. This is the situation of last 7 days test positivity rate. I've only picked up the districts with more than 10% positivity rate during the last 7 days. Andhra Pradesh has 2 districts now, East Godavari and Visakhapatnam. Arunachal has many districts, 9 districts exactly, and with the positivity rate, you're seeing Upper Siang is 73 and Lohit is 54. Upper Subansiri is 33 and Lower Siang is 28.5. So Arunachal is still suffering. Assam is still having 2 districts. Goa 1 district, Gujarat 2 districts, Vadodara and Ahmedabad. Haryana is having 5 districts, Kaithal, Bhiwani, Charki, Dadri, Hisar and Faridabad, more than 10%. Himachal is having good number of districts. If you look at Lahore, Spiti, Bilaspur, Kinnaur, Hamirpur, Mandi, Kullu, Shimla and Sirmaur, where last 7 days test positivity rate has been more than 10%. Next slide, please. Now, Kerala is still having Idukki with 37.7, Kottayam with 37.4, Kollam with 35.3, Wayanad with 33, Alappuzha with 32, Thiruvananthapuram 29, and so on. So Kerala and Arunachal are 2 states with areas of deep concern. Ladakh is having 10. Madhya Pradesh, Sioni, Bhopal, Raisan, and Vidisha. Maharashtra, number of districts less than more than 10%. Amravati, Buldhana, Gadchiroli, Nandurbar, Nagpur, Hingli, Pune, Washim, Yavatmal, Wardha, and Usmanabad. So it has traveled now in the interior districts of Maharashtra, where the test positivity rate has been more than 10% in the last 7 days. Manipur again is having Karching, Kakching, Imphal East, Imphal West, Tengonopal, Vishnupur, and Thoibol, more than 10%. Meghalaya is having 2, West Garo and North Garo. Next slide, please. You're having Mizoram, which are again an area of concern with Champhai 42%, Aizawl 38%, Lunglek 34%, Sirship is 28%, and number of other districts more than 10%. Nagaland is now having 4 districts, more than 10%. Pondicherry district is more than 10%. In Rajasthan, a huge number of districts is still positive. Hanumangarh, Chittorgarh, Pratapgarh, Jodhpur, Bharatpur, Jaisalmer, Raisamand, Banswara, Sikar, Barmer, Bundi, Jaipur, Udaipur, Baran, Tonk, Sidi, and Bikaner. And Sikkim, East, South, and West districts are more than 10%. India total is 4.89%. Though overall less than 10%, but I've shown you 123 districts are more than 10%. This is the global situation. If you look at cases newly reported in the last 7 days, globally it has been, if you look at the figure, it is at the moment, it is 1,74 lakh in the last 7 days, the globally, out of which 15,35,000 USA, Germany 13,38,000, Russian Federation 12,79, France 11,84, Brazil 11,62, Netherlands 8,50,000, Turkey 7,12,000, Japan 6,58,000, and India. Look at it. Last 7 days, India is now number 9 in the world. It has never been that low ranking, and that's a good news. India is now seeing a good low number of cases, so it ranks 7th in terms of ranking in new cases. Next slide, please. But if you look at the data of deaths newly reported in the last 7 days, India is ranked number 2 with 7,122 deaths reported in the last 7 days, and USA reporting 17,000 deaths in the last 7 days. Brazil, 6,000 deaths, Russian Federation, 4,774 deaths, Italy, 2,400 deaths, France, 2,300 deaths, Turkey, 1,600 deaths, Colombia, 1,600 deaths, and Argentina, 1,500 deaths in the last 7 days. Next slide, please. Now, another important event which has happened during the week, Act A advocacy. Let's listen to the World Health Organization on this important event of global significance which affects India as well. It is an important event which all of us should be aware of. Let it play. Act as accelerator will impact our ability to manage all the pandemics in the current pandemic as well as future pandemics. Unless we collaborate, cooperate at the global level and put out the best, whichever country offers for the whole world, the world will never progress in science. And without science progressing, mankind cannot progress. Could we have the video, please? Shivang, is there any problem in the playing the video?
Of the ACT Accelerator, His Excellency.
Depending on where you live, it might feel like the COVID-19 pandemic is almost over, or it might feel like it is at its worst. But wherever you live, COVID isn't finished with us. This knows no borders. And as we all know from Omicron, any feeling of safety can change in a moment. We know this virus will continue to evolve. But we're not defenseless. We have the tools to prevent this disease, to test for it, and to treat it. Where people have access to those tools, this virus can be brought under control. Where they don't, this virus continues to spread, to evolve, and to kill. The biggest barrier we face to ending the pandemics as a global health emergency is ensuring all people in every country have access to those tools. The ACT Accelerator is vital for this mission.
President Minister of International Development.
As outlined in the financing framework we're launching today, the ACT Save Lives or emerging. That includes an urgent financing gap of $16 with the remaining dollars to be self-financed by middle-income countries supported by multilateral development banks. We call on all higher-income countries to play their part in fully funding the ACT Accelerator and ending the pandemic as an emergency.
16.2 billion US dollars pales in comparison to what the developed economies is. South Africa, Norway, Kingdom share of financing to act accelerator agencies. The global targets for access to vaccines as the pandemic in 2022, access to COVID-19 tools persists. The longer the pandemic will persist, the end of this pandemic is in sight, but only if we act together for equity and for solidarity.
General for the World Health Organization will give the opening remarks.
All political leaders must now do what they can to close this financing gap. We know that unless COVID-19 tools become available to all, it is no mystery, infection rates will stay high, and patients, health systems, and economies will suffer. And new viral strains may evolve, posing a threat to all of us once again. So investing in ACT-A is the mutual interest of all countries. It needs to be brought to the attention of the meetings that are coming up in G20, G7, and other circles. And I salute the Secretary General for raising this issue in all UN contexts available. Because this is an equity imperative. It is sound economic policy. It promotes global health security and, as I said, global public good. We must achieve a fully financed ACT-A as soon as possible.
Hearing from epidemiologists and other.
So this tool of global cooperation will strengthen our strength in terms of being able to manage the global pandemics as it is happening now and as it will happen in future. Now, this is the graph of the pandemic. You are seeing how now it has started coming down. The contribution of Americas in green is clearly visible. Next slide, please. Next slide. Globally, during the week, the number of new COVID-19 cases decreased by 17% as compared to the number reported during the previous week, while the number of new deaths increased by 7%. Across the 6 WHO regions, over 19 million new cases and just under 68,000 new deaths were reported. As of 6th of February, over 392 million confirmed cases and over 5.7 million deaths have been reported globally. At the regional level, the Eastern Mediterranean region reported an increase of 36% in the number of new weekly cases, while all the other regions reported decreases. The region of the Americas, 36%, the Southeast Asia region, 32%, the African region, 22%, the Western Pacific region, 8%, and the European region, 7%. The number of new weekly deaths continued to increase in the Southeast Asia region, 67%, and Eastern Mediterranean regions, 45%, while the number remained similar to that of the previous week in the region of the Americas and the European region, and decreased in the African region 14% and Western Pacific region 5%. At the country level, the highest number of new cases were reported from the United States of America, 18,74,000, 50% decrease, France with 26% decrease, Germany with 22% increase, Brazil with figures similar to the previous week figures, and India with 41% decrease. The highest number of new deaths were reported from the United States of America with 14,090 deaths, 15% decrease. India, 7,888 new deaths with 69% increase. The Russian Federation, 4,686, similar to the previous week's figure. Brazil, 4,600 new deaths, 39% increase. And Mexico, 2,910 new deaths with 48% increase. Next slide, please. This is the data table which I talked just now. where you've seen overall decrease of 17% cases week on week and 7% increase in deaths week on week. Next slide, please. This is the map of the world, which is showing cases per 1 lakh population reported by the countries for 7 days. The highest is you are seeing is the entire Latin America, Australia, the entire Europe, and USA. Next slide, please. This is map of the world with number of deaths per 1 lakh population reported by the countries during past 7 days. And the darkest color you are seeing still is in USA, part of South America, and Russia, and part of Eastern Europe. Next slide, please. Here, before we end, we again take a look at air pollution, which is a public health emergency. Let's listen and understand how public health emergency and COVID-19.
Why does WHO consider air pollution a major public health emergency? If you live in areas with high levels of air pollution, does COVID-19 impact you differently? Hello and welcome to Science in 5. I'm Vismita Gupta-Smith. We are talking to Dr. Maria Neira today. Welcome, Maria. Maria, let's start with, why does WHO consider air pollution a major public health emergency?
Hello, everyone. Well, when you have more than 7 million premature deaths every year, every single year, associated with exposure to air pollution, I'm sure that everybody agrees that this is a major public health issue. Actually, 9 every 10 people around the world, particularly those living in cities, are breathing air that is not consistent with what WHO consider the good standards, according to our air quality guidelines, for breathing and still be healthy. And you know, for many years, we thought most of the diseases linked to exposure to air pollution were considered only to be affecting our respiratory system, and it's still true, very much. Exposure to air pollution is responsible for chronic obstructive pulmonary diseases, lung cancer, pneumonia, name it. But in addition to that, we know now that these toxic particles will come to our lungs, and from there, through the bloodstream, will reach our cardiovascular system and then be responsible for ischemic heart disease, for neurological disorders, for stroke, for neurological problems as well in general, and reproductive system issues. So, as you can imagine, all of those reasons tell us, consider that air pollution is one of the biggest public health issues we are confronting today.
Maria, if a person is living in a highly polluted environment where the air pollution levels are very high, does COVID-19 impact them differently?
Yes, we have now more and more scientific evidence. One reason is that exposure, long-term exposure to air pollution will affect your immune system and therefore will make you more susceptible to any type of respiratory diseases. And obviously COVID-19 is a respiratory disease. In addition to that, we know that exposure to air pollution will increase the risk for chronic diseases like cardiopulmonary, like metabolic diseases, diabetes. And we all know now that those diseases are the so-called comorbidities that will increase the risk for more severity and even lethal outcome if you are a patient with COVID-19. So yes.
Maria, when we think about air pollution, it seems like the scale is so big, and what can we do to reduce it? Share with us some examples of initiatives that governments and organizations took which actually reduced air pollution.
Well, clearly the best way to reduce air pollution will be stop burning fossil fuels. I mean, that combustion of the fossil fuels is contributing not only to climate change, but to generate this high level of pollutants that then end up in our lungs. So changing that policy around which source of energy we are using will be one of the most effective. Legislation, go for enforce the air quality guidelines of WHO. But if we go to concrete measures, of course at the city level you have mayors now going for changing the transport, the public transport system they have, promoting a more sustainable ways of public transport, reducing the use of private cars, going for more efficient energy use of our buildings, making sure that they reduce the traffic congestion in certain areas. And we can see that all of those measures are immediate, they have immediate positive outcomes. Obviously, as an individual, the best you can do is to put pressure on your politicians, on your mayors, make sure that there are systems to monitor the air quality that you are breathing every day in your city, and by doing so, ensuring that measures are taken at the political level. If the situation on air pollution is really bad, if we take measures, there is optimism. You can see that in European countries, for instance, or North America, the situation improved very much in the last 20 years. We are still far in other parts of the world, and we still need to put in place measures on sustainable transport, clean and modern use of energy sources, and all our way of consuming, recycling, and therefore we will be able to tackle this huge problem of air pollution. Tackling the causes of climate change will bring enormous benefits as well on reducing the causes of air pollution and therefore contributing enormously to our health.
Thank you, Maria, for explaining this link, this interconnectedness between our health and that of the planet. Thank you very much. That was Science in 5 today. Until next time then.
So you've had vaccines, act accelerator, and air pollution impacting the epidemiology of COVID-19. How are we connected? How we are connected with the planet's health? How we are connected with life in general, and our life is not isolated. So in the end, I would like to thank you for your generosity in giving me attention during my presentation. Thank you so much.
Thank you, Dr. Rajiv Jain sir, for giving the insight about the COVID-19 pandemic. As DG WHO, he has told that COVID is still not over, and any feeling of safety, it can change anytime as the virus is still evolving. And what other senior international leaders, they have told that equity of vaccine is very important, and the solidarity is important for the public good. So we have to maintain the solidarity amongst ourselves, and accordingly, then only we can mitigate this COVID pandemic. And sir, you have given a very good insight about the 11th February celebration of this International Day for Women in Science, and the video of Dr. Maria von Kerkhove, it was really very good, and Dr. V.K. Paul's celebration about this mRNA vaccine and Indian platform which they are developing, that will be a great help for India, where they will be having intradermal vaccine also, and it can be used for development of other vaccines for other disease also. And these vaccines, they will survive the normal cold chain also, so we don't have to freeze them below minus degrees centigrade. So that will be a great help for a country like India. And 96% of first dose coverage by Indian population for COVID-19 vaccine is a great achievement for India, and this will definitely help in mitigating COVID and making it endemic in India. And lastly, regarding this air pollution, why WHO considers air pollution as a public health emergency, that was also quite enlightening. So any questions from the learned panelists? If you have, you can raise your hand or unmute yourself, and you can ask.
I would like to congratulate Dr. Shyam Pingle also because he is in the panel. He has been re-elected for a second term in the International Commission of Occupational Health Board. That's a proud moment for India that two learned occupational health professionals from India are now represented in the global board of the International Commission on Occupational Health. This is for the first time that India has two representatives in the ICO board. Congratulations, Dr. Shyam Pingle, as well.
Thank you very much, sir.
Thank you so much, Dr. Jain, and congratulations to Dr. Sandeep.
Thank you very much, sir. So there is one question from Dr. Damodar Lele in the Q&A box. Has virulence of COVID-19 virus gone down and people are just getting better without any treatment? Are we giving undue credit to vaccines for preventing hospitalization or mild form of disease? Is it a normal phenomenon of registration of infectious disease that is becoming apparent now?
Interesting proposition proposed by Dr. Damodar Lele. I would say nobody is giving credit to vaccines for that matter. What is important is a multiplicity of measures available in a community where only dynamic multiple control strategies will work. Nobody should ascribe success to one particular measure of prevention or control of a disease. It doesn't happen in the real world. All the more so in COVID-19 because of the simple reason it is a viral infectious disease transmitted through air. So the vaccines have only prevented, very importantly so, they were never designed to prevent infection, number one. They were only designed to prevent, number one, hospitalization, number two, use of intensive care measures like, the life-saving measures like ventilators or death. These were the three specific gains that vaccines achieve. Now, Omicron is a different kind of warning sign that clearly shows that the virus is evolving faster than we think. How it will take shape in future, we do not know. And please remember, pandemics never finish with 2, 3, 4 waves. They remain till it becomes endemic. So there is a battle going on between mankind and the virus is evolving fast. That is the only lesson we could learn in the last wave in India only. But if you look at its evolution in USA, it's very much different. So each society, each country, each district, in fact, is following a unique trajectory. There is a lot more to learn, and we do not yet have learned the final lessons. I think that is the major lesson that we should learn from second wave and third wave together.
Another question is, sir, you analyze the situation and data so it is a compliment. You analyze the situation and data so beautifully and clearly. Then why do you need to show video of WHO or such foreign personnel? You summarize everything very well. That is
wonderful. I'm happy that somebody asked this question. Why? Because of simple reason that these people, the World Health Organization, is authorized under the International Health Regulation of the United Nations to manage the pandemic. Pandemic is a global disaster. Nobody from India can manage the pandemic. Nobody from USA, nobody from Africa, nobody from China can manage a pandemic. It's a global health emergency. And please remember, this is not the end of the pandemics. Pandemics in future will take different shapes. So only World Health Organization, which is the only global body of 194 countries with expertise and resources at its disposal to help guide and manage the pandemic. And that is precisely the reason I bring forth original videos which I received through email and a dedicated platform where they compress and give a 5 minutes edited version for all of you to hear and watch, because only then you professionals from AUHD and IOH will be able to understand who are the people who are managing the pandemic sitting in Geneva and how difficult is the task to communicate the diverse nature of the pandemic across the world. It is possible for normal human beings to belittle the life of a scientist sitting in Geneva in World Health Organization. But you saw the video of Dr. Maria Van Kerkhove. She's a human being. And you understand why she is as she is today. That's because of the hard work she did for H5N1, for MERS, and the life she had started from USA to Cambodia, and now sitting in press conferences. It's not a one-day story. She just happened to be there during the pandemic. And that's the reason I want you to have the original source, which will give you the real authenticity and the vision which is envisioned by the people sitting in Indian government, like ICMR DG or Niti Aayog member. Originality can never be replicated by me or anybody else. They are the real people who are handling the situation, which is unparalleled in the history of India.
Yeah, providing authentic information to everyone is our pillar for extending all the information, which is authentic information, which is there through our Enoch DigiConnect webinar. And this we are continuing for almost last 2 years. And as rightly said by Dr. Rajiv Jain sir, that there is no substitute for hard work. So hard work we all need to continue, and we all are doing this as a part of our responsibility. And luckily, the theme which was declared in the last ICO Congress also, that was the global responsibility for workers' health. That our efforts, they very well coincide with this theme, and we will definitely continue with our efforts towards this. And we need to focus on, as the President ICO, he said that we have to focus on the 3 phases of the occupational development at the workplace, that is external, internal, and the social environment. So we are all focusing on all these aspects. We are all taking care of our employees at our workplace by mitigating the environmental factors, by taking care of their internal factors, personal health, and the social and environmental health also. So environment and occupational health initiatives, they will continue, and this will definitely go a long way with support and participation from all the learned panelists and the participants. And all these recorded video sessions, they will be available on our Enoch DigiConnect webinars platform, YouTube channel. And more likes are now coming, and this will continue, and it will go a long way, sir. So with this, I think we can conclude this session. It's almost 1.5 hours now. So thank you very much, Rajiv Jain sir, and thanks all the participants and the panelists for sparing their valuable time. We'll meet next week at 6:30 p.m. with a new topic with a new faculty, and especially COVID Epid update with Dr. Rajiv Kumar. Thank you.
Thank you so much.